Some of you watching this today might know someone that works in healthcare or work there yourself. And I've had the honor to work alongside these healthcare professionals. But some of you might not have any idea what they do day to day. So the average doctor in their day, they might do something like communicate with nurses, nurse practitioners, residents, medical students, talk with dietitian, registered nurses again and again, continuous conversations. They might check emails, talk with patients, write down notation, and the list continuously goes on, more documentation, more work that they have to do. And seeing this, all of this has to be done on top of live a normal life as well, family, kids. So in seeing this and being able to work alongside clinicians as a technologist, I might be concerned and say, you know what, don't worry. I'm here, I'm going to take over some of your work for you. I'll take care of some of the writing, some of the work that you have to think about so you can focus on high value things. And in doing this and offering this, I would say, don't worry, also you can review everything I do for you. So naturally there might be a lot of questions, like who are you, why are you in my clinic, do you have credentials, like are you a student, why are you taking over this responsibility, that is mine. So why is it when artificial intelligence does the exact same thing, we call it revolutionary, it's changing the world. So as I knew it, working with clinicians in technology, they thought, they authored, they decided. That was how we worked together. And this has quietly changed over the last couple years. But to explain this, I want to bring you back to the before times with healthcare technology. So with healthcare technology, it kind of lived in the intersect of three things. The top is, of course, health. And this is not just exclusively physicians, this is nurses, this is pharmaceuticals, it's a very large field, health. And then from there, the software that they use. And this could be simple as like emails, but as well as like an electronic health record, which is the digitization of the clinical chart. And before, there still was AI, but it was considerably smaller. So in 2021 in Canada, about 2% of clinicians used artificial intelligence or machine learning in their practice. And it was there before, it wasn't ubiquitous. Some used it for image classification, risk stratification, but it was a very simple system before. And while you might look at this and see a framework, I'm trying to help you describe what healthcare technology is. In the top, I actually see my mother, who's a nurse. She taught me what it was like to work in a very busy field and actually still care for people. It inspired me to go down with health and work with health. For software, my dad, who I call a nerd, I always say my mom's a nurse and my dad's a nerd. And he was a self-taught programmer in the 90s. And with him was also my uncle, who worked in artificial intelligence since the 90s. He was working on things like neural networks for cancer diagnostics. And needless to say, it was a very interesting conversation at the dining table. And I heard the word AI by the time I was 5. So this is my family. And this is why when I found this field, it just clicked. Because it wasn't foreign, it was just home. And the question that we always ask is what people can do with technology to better the world. And an example of this was my grandfather had trouble reading and just seeing. He was visually impaired. So they built a system that was magnification with better lighting so he can read. And then that wasn't enough. So in the late 90s, my uncle and father built a system to help him read on the computer. Because what was there before for text to speech sounded so robotic and unnatural, and they managed to get over 1 million downloads in the early 90s. So technology can be used to help people was built into my life, and that question is my life goal now. And to accomplish this goal, I had to go back to school, here at this very institute, Lakehead University. And then from there, I was able to work alongside wonderful clinicians who taught me quite a few things. My very first mentor is here today, Dr. Arnold Kim. And he taught me that even though it's the status quo with technology, it has to be changed. No matter where you're coming from, small town, big town, you can enact change. And with this, I had the opportunity to go to Harvard and MIT for an innovation bootcamp on the topic, because you must research, but you also must enact, and to enact something, you must go the commercial path and help deploy it. And ultimately, I'm here today. This is my field of choice. And the question that my specific subfield is to build things that clinicians want to use. And this is a very simple sentence, but it's surprisingly difficult. Building for doctors is very challenging. Some of the reasons might be they're not overly tech savvy. One time I built a feature, I showed a doctor, and they said, I hope I retire before this comes out. They dislike change. We all dislike change, of course. But doctors in particular, because if you change too much, the patient and the doctor will suffer, ultimately. From there, they've been overpromised, this technology will change your practice, is a common line. And they just have a general bad experience with software. Most of their software, they don't get to pick, it's just chosen for them. I mentioned the electronic health record, and that's just the digitization of a document, and now they have to sit there and work a lot on it. And the list goes on. So that's why they're busy. It's not just the human connection, it's not just working on the patients, it's actually just sitting there and working on their computers. That's what we call the administrative burden. And an example of this was a study where 200,000 US doctors in the outpatient environment, for every 8 hours they spent with patient time, they spent 5.8 hours on the computer. And that's just clicking and documenting and repeating. Not spending time with patients, not even looking at a patient during the visit and just writing so that they can go home on time. It's less time with patients, more work at home. There's a term called pajama time, where a doctor is working at home in their pajamas on their computer to document. And burnout, leading cause of burnout. But that's why I wanted to work with them. I wanted to build, I wanted to refine, review, and build and help these clinicians with their life. And it was absolutely worth it. Even with all of its challenges, it's still worth it. Because if we don't build it, the patient and doctor will pay the price ultimately. And then November 2022 happened. Large language models. This old framework now looks like this. It's the biggest thing that we talk about day to day now. And it wasn't the clinicians who changed. How could they in a matter of 3 years? It was the problems we can solve. That administrative burden, that documentation. You know, I worked in natural language processing before, and you could only do so much, but now you can do so much more. And now the promise, use AI, you get more time with patients, you can actually talk with them, you can do less work at home, and go see your family. That's why we see it in the States, through the American Medical Association, a huge uptake in artificial intelligence. In Canada, we went from 2% to 20%, with an additional 40% wanting to use it and willing to use it. So I'm going to just explain what a modern 10-minute visit might look like. For some doctors, not every doctor has adopted this. Not everyone will. But there's a technology called Scribe, and a Scribe technology listens to the conversation. You might have done this in your meetings, and the doctor talks, the patient talks, and it goes back and forth. It goes back and forth between the two until ultimately the conversation is fully recorded. And what that represents is a 10-minute discussion. And that discussion is then summarized and written in a note. It is then through the research, it's going to be doing research on that particular notation. It goes forward and does referral letters. It goes forward and does forms for the doctor. Right? This is a pretty fancy system that's really helping with that administrative burden. But then the doctor ultimately reviews. Right? They don't just send this off. It's still their license. They still have to give that proper documentation a review. And that's why we're seeing it look like this, to start reducing to maybe look like this. And this is the new era. This is new technology. However, there's a big shift from authoring to reviewing, and that's what we're all doing with AI right now. We are no longer authoring everything, we're just reviewing what AI is doing. And then from there, what it looks like now is, previously doctors used to use software that looked like this, where they just use it back and forth. AI used to look like this, back and forth, a very simple system. But that has shifted to doctors using an AI system that continuously works in tandem with itself. So the old model was simple. They can use a software, but the new model is complex. It's taking over a lot of the working process. And I'll give you an example of the 10-minute visit, once again. So the transcription software continuously records 10 seconds at a time. And this is a full 10-minute conversation. And then the AI system is going to select what it thinks is most relevant to go forward. And the rest is removed. 6 minutes removed. Not the doctor picking this. This is the AI system picking this. And from there, it is not going to just paste that to the medical plan. It's going to rearrange and add words as well. Once again, an AI system rewriting the note on behalf of the clinician. What gets added, what gets removed, what gets left out, the AI is picking that. Research is done on behalf of the doctor, where it looks at the body of research, the entirety of medical research for evidence-based medicine. It picks the papers that the AI thinks is most relevant, puts it together, and writes a summary. Once again, the AI is picking all of this. It's recording, it's removing, it's editing, it's researching, it's writing, all on behalf of the clinician. And this is beyond an assistant. This is decisions being made. And this is not even to account for the failure rates of transcription, which is about 5%, or the hallucinations that occur with AI models. This is not also just healthcare. This is every single field, law, programming. The list goes on. We're all automating these tasks. We're now reviewers. We're not person authoring. And this is not just a tech trend. This is a complete restructuring of what we know knowledge work to be. This is a renaissance. And you might be wondering to yourself, should we stop it? Can we stop it? I mean, we've all seen this type of innovation before. The dot-com boom, maybe we read about it in books. The printing press, the steam engine. This is innovation and it can't be put back. And these systems are going to get more and more complex like this, where they're going to do more tasks on our behalf, and they're going to get better. And we won't have to review them as much. Maybe 5 minutes, 3 minutes, 2 minutes, 1 minute. And when I look at this, this represents maybe your tasks are a little bit more complex and someone else's aren't. So your system will take on theirs. This is job loss. This is what I think about when we talk about job loss due to AI. And on top of that, it's also the environmental impact, the effects on our cognition, where we're offloading our thought process to these machines, the error rates, the trust that we are lost in these systems when someone sends that AI email to us and we just don't trust them the same anymore. But ultimately, it is here to stay. This is the new normal. And that's okay. You know, personally, I don't want to go back to what it was, because I know the problems that we can solve for these, not just healthcare workers, but across the world, where we're able just to do more and more. We're able to just do more and more for them, and I don't think it's time to stop this. And what you can do at home, you can only do two things with artificial intelligence. You have control over what you put into them and what you take out of them. And when we look at this, you don't just sit there as a doctor and let the transcription run itself and then it does its summary. Like maybe you put your impressions in at the beginning, because the system will run based on those impressions. Because it's not just about the conversation that you had, it's the intuition you had with the patient, the way they said something. That's not captured by AI. The way that you think, the way it reminded you of something. So when you use these systems, ensure that you put a lot at the beginning, so that the rest of the task itself will be based on that. And then at the end, before you send it to someone else, before you put it on the medical record, ensure that you review. Because like I explained, you didn't author all of that. The system did. So it's up to you to review it. It's up to you to do the additional work, the extra work that is required for these systems. So it's about more of you in the process, not less. Thank you very much.